Yeah, please go ahead. Yeah.
So the patient is a known case of, diabetes, and I think this is an increased radiotracer uptake, which is done for intestinal motility. Um,
So what are the normal
I think, yeah.
limits? How much a tracer should be there in which part of the GI tract at what time?
Okay. I'm not sure, maybe at around 15 to 20 minutes, the gastric emptying should happen into the small bowel. Like 20 minutes
No problem. No.
approximately.
Can you give me a few causes for quick gastric emptying?
Quick gastric emptying.
Yeah.
Okay. Could be some inflammatory disorders like inflammatory bowel diseases or celiac disease.
Okay.
Mm,
Anything else?
Zollinger-Ellison syndrome
Okay.
or
Anything else?
yeah, or any other um,
Okay. No problem. Yeah. I
yeah.
think let's go to the next case. You can ask for control one more time.
Requested, sir.
Yeah. I think maybe scroll a little slower. You might. Yeah. Click once
Okay.
and scroll. Yeah.
Okay. Okay, it's scrolling. Yeah. So I'm presented with axial sections of CT, abdomen, and pelvis. It's a plain study. I'll just scroll through the images before I comment.
Are you sure it's a plain study?
Uh, okay. No, it is enhanced. No, it's a portal venous contrast.
Okay.
Yeah, it's a portal venous phase. There are multiple gallstones, and there is some fat standing involving the mesentery in the paraiotic region with some enlarged paraiotic lymph nodes. Mhm. The kidneys appear normal, adrenals are normal. Um, this fat stranding is extending into the pelvic mesentery also. Uh, I think this is the last section also.
Yeah, no,
It's not
I
including the
think
one.
it's
Okay.
yeah, it's loading. I think so let's go
Oh,
back to the upper part. What are you seeing there
okay.
in the upper part where you were telling me about the notes? Can you go up? Can you go
I
up?
Yeah, I'm trying to go up, but it
Yeah,
is
yeah. Can you leave the
yeah.
mouse once? I'll just try once.
Okay.
Yeah. Can you tell me what is happening here?
Okay. So there is fat standing in the mesentery, and there are some enlarged paraiotic lymph nodes. I think this could be sclerosing mesenteritis or mesenteric panniculitis. There is no evidence of a hypoechoic halo, but these would be my differentials. It is not concentrated in the periaortic region. I would also think of retroperitoneal fibrosis. Um, I want to see the pancreas, if pancreas is normal or if there are any inflammatory changes involving the pancreas. Um,
Okay. So I'll just scroll up and show you the pancreas. This is the pancreas.
I think pancreas is looking, yeah, I think pancreas is looking normal.
Okay.
Um, there is no evidence of calcification within this mass lesion, or there is no evidence of bowel tethering to suggest
Mhm.
a carcinoid, or there is no evidence of bowel obstruction or dilatation. I'm just looking for any evidence of bowel thickening, associated bowel thickening.
Okay.
Um,
And think so I'm gonna scroll a little down now.
okay, so yeah, I can see that the
Yeah,
left sigmoid colon is
scroll. Now you can scroll. Yeah.
okay. I have the control now, sir. Yeah, okay. So I think the left sigmoid colon, the wall of the left sigmoid colon is thickened, and uh, Okay. There are small diverticula with fat stranding in the surrounding mesentery, and I'm just trying to look if there is any evidence of a focal perforation. And also in my routine practice, I would like to take a look in the lung window to see if there is any evidence of pneumoperitoneum. And I would like to see if there are any strictures or abscess formation. I do not see any abscesses in the pelvis, or there is no evidence of fistulas, intracutaneous fistulas, or fistula with the other parts of the bowel. I think this is a case of diverticulitis, acute diverticulitis, and this is an emergency. I would like to inform these findings to the referring doctor immediately. Mm.
Okay.
Yeah,
Okay.
and also I would like to see it in the lung window to see if there is any pneumoperitoneum or focal perforation.
Okay. Okay. Cool. Yeah. Thank you. So we'll go to the discussion of the case. I think so. The
Mm.
first case was yeah, let it load. Yeah. So this was
Emphysema.
this and this nuclear scan is called gastric emptying scan. Okay.
Oh.
So we technician 99 is labeled to a meal, and we ask the patient to swallow it, and then we take at uh, each time interval at 0 minutes, 30 minutes, 60 minutes, 120 minutes, and 240 minutes.
Okay.
We expect 50% of the tracer to eliminate at the end of 1 hour, and 90% of the tracer to be eliminated by 2 hours, and nothing to be seen at the end of 240 minutes.
Okay.
Okay. So anything which is going against this suggests there is delayed gastric emptying, which is most commonly associated with diabetes. Okay.
Okay.
So what we do here is if there is another chart which is called the anterior and posterior count. So we take an AP view of the nuclear scan, and we take the counts or number of tracer that is present in the stomach, and we take the counts. And if, as you can see in this chart, it is going down. Okay. And by the time
Yeah.
it's 240,
Mm.
it is 0, 0. That means it's
Zero.
completely gone from the stomach. That
Zero.
the percentage of retention within the
Yeah.
patient's stomach is 0 at the end of 240 minutes. So this was a completely normal scan. Even though he's diabetic, this was a normal scan. Okay.
Okay.
So the whole point was just to show you how a gastric emptying nuclear scan will look, and this is how you should be telling. Okay. The graph is actually showing you the retention, which is going down to 0 with the each time interval. Okay. So this is how the tracer will go down. Okay.
Okay.
This case, the fact that there is some fat stranding here should make you think that are we missing out something, right? So if you go back here, if you can see, this is the portal vein, this is the splenic vein, and if I scroll a little back, I can see something coming off from it. Can you see the small vessel?
Yes.
Yeah. Do you know what the name of that vessel is? Which gives off a branch from the splenic vein? Which joins to the splenic vein. It's called inferior mesenteric vein. Okay. So basically, this is inferior mesenteric vein. You can see an air pocket here within that vein?
Yeah.
Yes. So this is IMV phlebitis. Okay. So that is why you are seeing stranding around that area. Okay. So that is the primary pathology here. Okay. Apart from which you're seeing a sigmoid diverticulitis. Okay. Can you see a focal diverticuli extending here down, and it's further going down into the left seminal vesicle? So there is a fistulous communication between the seminal vesicle and the diverticulum. With the sigmoid colon. And if you go further up, with the uh, urinary bladder, there is an ill-defined fat plane, but not very. There's no air pockets within the what do you say, within the urinary bladder to suggest there is a fistulous communication, but the fat plane is definitely gone. Okay, so there are two different entities that we are seeing in this case. Okay, so please keep a check on this. IMV phlebitis might come up in the exams. Okay. Then I think I showed you one more, but I don't remember what case it was.
Emphysematous changes were there in the lung.
Yes. So that case was a case of panacinar emphysema. Yeah. So it's just involving the lower lobe, and the patient also has a background cirrhosis. So it was a case of alpha-1 antitrypsin
Alpha-1
deficiency.
antitrypsin deficiency.
Yeah. Okay. So thank you so much, Rupa. I think you did well. Just keep seeing those cases, GI cases. Maybe you might just need a brush up on the GI cases. Obviously, the interface will be far much better. Today, I think the internet is quite bad for me. So I'm really sorry for that experience. Okay.
No problem.
Yeah. Thank you so much. Yeah. Candidate 4, are you there?
Yeah, I'm
Yeah.
here.
Hi.
Hi.
Okay. Yeah. Let's start.
Provided lateral sagittal view of the cervical spine. I'm going through my checklist, look for any evidence of abnormality. I can see that in the spinous process of, I think, C7. Let me count down. 3, 4, 5, 6, 7. Yeah, I can see that there is a fracture involving the spinous process of the C7 process. Along with that, I'm looking for any evidence of other abnormality. I also suspect abnormality in the C8 vertebra. Other than that,
you can ignore. Yeah, you can ignore you can ignore that. Anything else?
Okay. I'm looking for any evidence of other abnormality.
This is a pediatric kid who has presented with sudden onset neck pain.
All right. The sudden onset neck pain in a pediatric patient, I'll be concerned for any. Okay. I'm going through my checklist again. I'm looking at the overall oropharyngeal airways. Okay, that is normal. And there seems to be an opacity in the upper esophageal airway, just below the hyoid bone. Suspicious so foreign body which has stuck there might be the cause. Other than that, the prevertebral soft tissues appear normal. There is no widening there, and okay, the facetal joints appear normal. Okay, I'm not quite sure what is happening here. In my
No
routine
problem.
practice, I'll also look
What
at
would you like to do
orthogonal
next?
views, and
Yeah,
I will also correlate
I have
with
a
the
frontal view
orthogonal
for
views.
you. I have a frontal
Yeah.
view for you. One sec.
On retrospect, this could also be a fracture of hyoid, but in pediatric patient, it is highly unlikely.
Yeah, one sec. I'll just give you a frontal view.
Is it up? Is it on?
Yeah,
I can
just a
see the
moment. I
views.
think my
Yeah,
internet
sure.
is weak.
Sure. Take it.
I think let's so this is basically what we saw on the ultrasound of the neck. I can show you the other images. Just have a look at these. These are spot images of the same patient.
Presented with the linear high frequency images of the color flow images of the ultrasound of the neck of the same patient. I think these are neck. I'm looking at lymph nodes, which are showing abnormal echogenicity, heterogeneous echogenicity with increased surrounding fat echogenicity with areas of, I think, early caseation. So in a pediatric patient, I would be concerned for an infection in this patient, which could be explained, which could explain the neck pain. If this patient had acute history, I would be concerned for maybe submandibular or parotoid infections. This was a long-standing infection. I would be concerned for tuberculosis, any other long-standing chronic inflammatory etiology such as sarcoidosis. If Also, if the patient has any trauma or any other etiology, this could also explain that this could be a reaction to just adjacent foreign body which has infected the nearby lymph node. So all in all, I think this is an infective process going on in this patient. In my routine practice, I will also look at the entire neck region for looking for any abscesses, especially posterior abscess, prevertebral abscess, and I will also look for any extension towards the mediastinum in this patient, look for lung infection associated,
Okay.
and any other abnormality. So I'll convey these findings to the referring clinician, and patient should be kept on antibiotics and kept on follow-up. Do I have that frontal
No,
explain?
actually, yeah, I think the
Okay, it's okay, fine.
my images are
Sure.
internet is
Sure,
pretty
sure.
okay. I think everything. Okay, let's see if this works. This case works. So this patient is a newborn. 2 days prior he was born and no movement of the left arm. Okay.
2 days prior, no movement of left arm. Okay.
Yeah. I think I'm having a very bad internet, so I think I'm so sorry, Dr. Balakrishna. I think my internet is weak. Shall
Sure,
we
sure,
work with your
sure.
side for the next class?
Yeah, sure, definitely. What was the case? Shall we discuss at least based on
Yeah. The first one was torticollis. So basically, I wanted to show you a case
Okay.
where there is that is a straightening of the cervical spine. In a
Okay.
pediatric child, when you see a straightening of cervical spine with no underlying fracture and sudden onset neck pain, think of torticollis. And then when you try to evaluate the reason for torticollis, cervical lymph nodes are one of the causes, which often happens with pediatric age group. Okay. So other
Sure.
cases, I think I'll show it to you next time for sure. Sorry for the inconvenience caused. Okay.
It's okay, sir.
Okay.
Sure,
I think
thank
I'll
you.
wind up the session right now. Yeah. Thank you so much, everyone.